I'm Jonathan Van-Tam, Deputy Chief Medical Officer, Department of Health and Social Care, and this is a short technical update about the COVID vaccine programme, which has been remarkably successful so far in the UK. I'm joined today by Dr. June Raine on my left, who is Chief Executive Officer of the MHRA, and I'm joined by Professor Wei-Shen Lim on my right, who is Chair of the JCVI Joint Committee on Vaccination and Immunisation subcommittee responsible for COVID-19 vaccines. We are now going to begin the briefing. The running order will be that Dr. Raine will say a few words first on behalf of our regulator, the MHRA. Professor Lim will then say some words from the JCVI perspective. I will then take some questions from members of the press who are online, and I will then conclude with some closing remarks. Thank you. So, without further ado, I will pass over to Dr. Raine.
Good morning. As the independent regulator for all medicines and vaccines in the UK, the MHRA has been continuously and rigorously monitoring the safety of the approved COVID-19 vaccines being deployed here. As part of our thorough monitoring of the safety of COVID-19 vaccines, we have been reviewing reports since February of extremely rare and specific blood clots with low platelet counts, the cells that help the blood to clot, known as thrombocytopenia, with the COVID-19 vaccine AstraZeneca. We've reviewed every case of these specific blood clots with low platelets as soon as we have received them, following up with the reporters for any missing data to help confirm the diagnosis. And this is done by our teams of safety experts, scientists, clinicians, epidemiologists who are investigating and reviewing and evaluating round the clock all safety reports, together with all other sources of evidence. And then, in addition, the Independent Scientific Advisory Committee, the Commission on Human Medicines, rigorously reviews these analyses. Up to the 28th of April, there have been 242 cases of these specific kinds of blood clots with low platelet counts. And with over 28 million doses administered by that date, that's an incidence of 10.5 per million. In terms of second doses, we know that there have been 6 reports under evaluation, and with around 6 million second doses given at that date, that is an incidence of 1 in a million. What this shows overall is that with support from the public and from healthcare professionals, our safety monitoring systems are working and working effectively. These extremely rare side effects have been identified and analysed by the best of scientific minds and enabled us to provide scientifically based, up-to-date information and advice to enable judgments on the use of the COVID-19 vaccine AstraZeneca. I can confirm today that the position of the Medicines and Healthcare Products Regulatory Agency remains unchanged, that the benefits of the AstraZeneca vaccine against COVID-19, with the associated risks of hospitalisation and death, continue to outweigh the risks of the vaccine for the vast majority of people. There is therefore no change to the approval. The balance of benefits and risks of the vaccine is very favourable for older age groups, but it is more finely balanced for younger people, and so we advise that this evidence should be taken into account when considering the use of the vaccine. I'd like to take this opportunity to thank everyone who has reported their suspicions about side effects to us through our tried and tested yellow card scheme. Every report counts, and by doing this, you have helped keep this vaccine safe. So please continue to report through our coronavirus yellow card reporting portal. And as with all medicines and vaccines, we will continue to monitor. We will be monitoring 24/7, and the public can be confident in the COVID-19 approved vaccines. Safety is our watchword, and patient safety is our #1 priority. Thank you, JVT.
Thank you, Dr. Rain, and I'm confident that Dr. Rain has explained the position of the MHRA to you, that there is no change in advice today. The Joint Committee on Vaccination and Immunisation, JCVI, has a different role. That role is not connected with authorisation of medicines and licences. It is connected with advising the government on how vaccines should be used as part of our public vaccination programme. And the JCVI does have an update for us, and Professor Lim will now talk to that. Thank you.
Thank you. The Joint Committee on Vaccination and Immunisation, or JCVI, is also an independent body, and we conduct regular reviews of our advice on COVID-19 vaccines, particularly to take into account new or changing circumstances. In the last few weeks, we have reviewed new data, which I want to share with you. If I could have the first slide, please. We've tried our best to understand the latest evidence from MHRA regarding the risk arising from extremely rare adverse events following the first dose of the AstraZeneca vaccine. We've also looked at data related to the control of COVID-19 infections in the UK and mathematical models of any further wave of infection that might occur later on this year. We've assessed vaccine supply forecasts and the level of vaccine uptake in the vaccine program at the moment. We've also looked at the speed of vaccine deployment. We note particularly the following things. We note that there is new evidence regarding the efficacy or effectiveness of vaccines, particularly in protecting people from severe disease. There is also very recently new published evidence to show that vaccines also offer some protection against transmission of infection. We note the very high levels of vaccine uptake and the high speed of the vaccine deployment program. It's the strength of the vaccine program over the last few weeks and hopefully continuing into the next few weeks that will protect us in the longer term. If the vaccine program continues from strength to strength, then a future wave of infection is likely to be smaller than previously anticipated, given all that we now know about the vaccines. And this is good news for all of us. To reflect these changing situations, JCVI agreed to update its advice. Could I have the next slide, please? Building on our previous advice related to those aged 30 years and under, we now advise that unvaccinated adults aged 30 to 39 years who do not have an underlying health condition that puts them at higher risk of severe COVID-19 should be preferentially offered an alternative to the AstraZeneca vaccine where this is possible and only where no substantial delay in access to vaccination might arise. The AstraZeneca vaccine is very helpful in that it requires less stringent transport and storage conditions compared to some other vaccines. That means that in certain settings, the AstraZeneca vaccine may be the only vaccine that is practical to offer. And in those circumstances, the AstraZeneca vaccine should indeed be the preferred vaccine. Next slide, please. Importantly, I want to say that this updated advice is specific to the current UK context. It is conditional on the following factors remaining favourable. That is to say, there continues to be good control of COVID-19 infection in the UK. There is good availability of alternatives to the AstraZeneca vaccine, and there is strong vaccine rollout. In other words, we maintain the speed of vaccine deployment and a high level of vaccine uptake. the size of any future wave of COVID-19 is greatly influenced by how well the vaccine program is going. Reductions in the vaccine uptake or the speed of deployment in the coming weeks will increase the size of any future wave. And in that scenario, any vaccine offered early is preferred to a vaccine offered too late. We can take the slide down. Thank you. Our other advice remains unchanged. There are no safety concerns in relation to the second dose of the AstraZeneca vaccine. So if you've had the first dose of the AstraZeneca vaccine and have had no problems from it, then please go ahead and have the second dose of the AstraZeneca vaccine. We also advise that all people who are offered a COVID-19 vaccine should have access to information about the benefits and risks of vaccination. We offer this advice, which places a high priority on safety in the hope that it will further increase vaccine confidence, so that those of us who are being offered a vaccine in the coming weeks can feel more confident and feel more able to step forward, accept the offer of a vaccine, and be vaccinated. By being vaccinated, we protect ourselves, and we now know that we also protect those around us. Thank you.
Thank you, Professor Lim. I hope you feel confident that the MHRA and the JCVI are really watching over this programme extremely carefully and very closely. The point has been emphasised several times already this morning about maintaining the pace and the volume of the vaccine rollout in order to control the disease in our country long term and to minimise the impact of any upsurge in cases potentially associated with a third wave. I can't overemphasise that enough. I can say to you on top that on current plans, our vaccine supply schedule will support the change offered by the JCVI without limiting the speed and scale of the vaccine rollout. I do expect that we are still on target to offer a first dose to all adults by the end of July. We will now pause the narrative and take questions from the media, after which I will offer some closing remarks. The first question is from Fergus Walsh from the BBC. Hello, Fergus.
Hi, thank you very much. Can I ask you, what would you say to a 40-year-old who's about to receive the AstraZeneca vaccine and is worried?
Thanks for the question. Would you like to start on that one, Wei-Shen?
Sure, thank you. A 40-year-old who's coming up for vaccination, I would encourage them to be vaccinated. The benefits and risk of vaccination far outweigh or are very much in favour of vaccination. And so I would encourage that person to accept the offer of vaccination.
Does that answer your question, Fergus?
Well, it does. But you said that I think the incidence is something like 1 in 60,000 for those in their 30s. Obviously, you have to have a cut-off somewhere, but the incidence in a 40-year-old, or the likelihood of having one of these very rare side effects, would be higher than in a 50 or a 60-year-old. So there will be concern about wherever you draw this cut-off line.
As we've explained before, the risk from COVID-19 is very tightly associated with age, and it rises very steeply with age. It is perhaps best pictured as the upward curl of an oncoming wave. On the other hand, the risk from one of these extremely rare adverse events is very, very low, first of all, and any gradient with age is very, very shallow, and perhaps you can picture that as a gently sloping beach with the oncoming wave. And where the up curl occurs is roughly around 40 years of age. And so there's really, it's not so easy to compare the risk-benefit below and above. But around 40, we see this very steep rise in the risk of COVID-19. And so the benefit from the vaccine certainly rises much higher than the risk from this extremely rare adverse event.
Thanks, Wei Shen. Dr. Rain, would you like to add anything?
Certainly. I think the analogy with the beach and the wave is actually a very helpful one, but perhaps to add some figures that may also illustrate what we're talking about. I've already mentioned that overall the incidence of these very rare cases per million is 10.5. And if I look at the age band from 40 and up, actually it's 10.1. And what this does tell us is the reason we rigorously monitor and follow up cases, because many factors influence reporting, and we try our very best to get the value that we need. But the figures that we're giving today help to illustrate why JCVI has given the advice, taking into account not only our data from Yellow Card, but a range of other important strands of information.
Thank you very much, Dr. Rain. So, look, I mean, Fergus, I think I'd just conclude by saying, you know, I'm not a member of JCVI, but I sit behind the scenes and I see everything that JCVI does. I'm with them every time they meet as an observer, and I think some very fine minds, some very good epidemiologists and vaccinologists have put their very best effort into calling this in exactly the right way. Thank you. We'll move on. And the next question is from Tom Clark at ITV.
Hi, thanks for taking my question. Firstly, can I ask, how concerned is the committee that this news could undermine confidence in the vaccine in younger age groups? And as we know from the epidemic so far, those age groups are so important in transmission of the virus. And what the implications would be if vaccine confidence was undermined. And secondly, could I ask about the alternatives to vaccines? You say the schedule looks like we can easily do this and vaccinate everyone by the end of July. However, will we be using the Johnson & Johnson, the Janssen vaccine as an alternative to AstraZeneca, given other European countries have chosen not to, given it shares, there's earliest indications it could share similar risk profile with the AstraZeneca jab?
Professor Lim, would you like to answer the first part of that question? And then I will answer that in company with Dr. Rain in the second part.
Certainly. I do want to first of all note that vaccine uptake has been very high so far, and that follows with the speed of vaccine deployment. And both of those things are excellent. We also want both of those to continue through the next few weeks, because that will protect us from a large increase in any future wave. The purpose of the advice is really to improve vaccine confidence, if anything, because the advice puts a high priority on safety. And we're trying to demonstrate that we are rigorously assessing the situation, and where appropriate, we will advise accordingly for the benefit of individuals and the public. And so we hope that the advice will, if anything, serve to boost confidence and allow people who are being called up for vaccination now and in the next few weeks, who are mainly younger people, to feel able to step up, accept the vaccine, and be vaccinated.
Thanks, Dr. Lim. I think I would just add to that by saying all of the opinion polls I read very clearly show that the British public has very, very high confidence in the vaccine programme in the UK, can already see what it is doing in terms of changing our future, and the data get better and stronger in terms of the layers of protection, not just the aversion of deaths, serious illnesses and infections, but now the prevention of transmission on top. For young adults in particular, we know they have higher mixing patterns. They're young and sociable, basically, and therefore they have a higher propensity for transmission. So continuation of the vaccine programme and maintaining confidence through the measures that JCVI have announced today is really important, not only in terms of the potential impact of continuing vaccination on keeping any third wave or resurgence smaller than it would otherwise have been, but basically because although we're in a very good epidemiological situation now, compared with a couple of months ago even, we don't retain control of this disease unless we continue the rollout of the vaccination programme. It is critically important. I'll now pass to Dr. Rain to begin some remarks about your other question, which was the Johnson & Johnson or Janssen vaccine.
Yes, turning to the Johnson & Johnson or Janssen vaccine, as you've said, there are pointers that may indicate a similar safety profile. What we're doing is working internationally with the jurisdictions where that vaccine is being used to learn as much as possible while our own approval process moves forward. And as you're hinting, it is really important that we will have choices for deployment, but our rigorous approval process is well underway.
Thank you, Dr. Rain. I'll just add a couple more comments on the Johnson & Johnson vaccine to say that as far as we anticipate, it may well be authorised as a single dose schedule, and that could potentially make it very important rather than no vaccine in populations that are hard to reach, where basically you have one chance of vaccinating them and little chance of calling them back for a second vaccine. There are going to be some niche uses where a single dose vaccine could be very, very important indeed. But to your slightly broader question, I do not anticipate use of Johnson & Johnson to complete the programme as the preferred alternatives to the AZ vaccine in the under-40s. Thank you. The next question is from Fatima Manji at Channel 4.
Thank you very much, Professor Van-Tam. You have been very clear about the risks relating to age, but can I just ask about gender? Because there is some evidence that women are more likely to develop clotting in relation to the AstraZeneca vaccine than men. So should all women be offered an alternative? Is that something you're considering? And secondly, can I just mention specifically for pregnant women, we know that Pfizer or Moderna is preferable for them, but we are hearing some reports that pregnant women are struggling to access those particular vaccines. So can you give us any update on that in particular?
Thank you, Fatima. Very good questions indeed. I'm going to pass first of all to Dr. Rain, who I'm sure will have the right answer for you on the distribution of the signal by sex. I will then pass to Dr. Lim, Professor Lim, I do beg your pardon, Wei Shen, who will give you further clarification on the point about pregnant women and so forth.
Well, thank you for raising this issue. It's an important one, and it's something that we at the MHRA are monitoring very carefully indeed. As you probably recall, we initially thought that an apparent difference in these extremely rare blood clots with low platelets, more preponderance in women, was due to the way that the vaccine was deployed. But we now know there is a very small difference emerging, and that is something we're looking into very carefully indeed, so that the appropriate advice can be given. But there are two key points there. One is that these are extremely rare, and that any difference we're looking at now is a small difference and one that we need to thoroughly investigate.
Thank you. Professor Lim.
Thank you. You're right. The JCVI offered advice regarding a preference for the Pfizer and Moderna vaccines for women who are pregnant. We did this some time back, and this was on the basis that whilst there are no trial data on any vaccines used on a large scale in women who are pregnant, We know from the US that the Pfizer and Moderna vaccines particularly have been given to a large number of women who are pregnant. They have not seen any safety concerns with the use of Pfizer and Moderna vaccines, and therefore we have said that there is a preference for using Pfizer and Moderna where that is available. We're not saying that the other vaccines are in any way harmful or should not be given, simply that where it's available, we should offer, if possible, the Pfizer and Moderna vaccines to women who are pregnant. In terms of the access to such vaccines, I understand there have been some reports of difficulties in accessing the vaccines. I certainly hope that operationally NHS England will be able to overcome those difficulties in access.
Thank you, Fatima. We're now moving to the eye and Hugo Guy.
Thank you. Could you please give us more information on the modelling you've done on what effect this decision will have on the speed of the vaccine rollout? You've said that the end of July target is still on track, but do you expect this decision to slow down the programme from its current pace of roughly 3.5 million doses a week? And can I also ask, there's likely to be a certain number of people under 40 who would much rather have the offered AstraZeneca vaccine in May, say, than wait for the Pfizer vaccine in June, having taken into account all of the risks. Are you recommending that there be some sort of opt-in programme so that people who would rather take the AstraZeneca vaccine early can do so if they want?
Thank you for the questions, Hugo. I think I'll take the first part of that and say, no, I know that behind the scenes it has been very carefully looked at about whether the supply schedules will support the change that is being advised to us by JCVI, and we are still on target to offer a first dose to all adults by the end of July. I do not expect this to change or limit the speed and scale of the vaccine rollout. Professor Lim.
So in terms of the second part of your question, if there is no delay in the offer of an alternative vaccine, then I guess a person will be offered the Pfizer or Moderna vaccine initially. If they then want to choose to have an AstraZeneca vaccine anyway, possibly without any particular delay or getting it any earlier, it may be possible for that to be arranged, but that will depend, I think, on the operational situation in that area. And that would be for the local or regional deployment teams to organize whether such an arrangement could be made. On the whole, for a mass vaccination program, we are not offering patient choice. So it is not a case that somebody turns up at a vaccination center and can choose which vaccine they will get.
Thank you, Professor Lim. I mean, I think the scenario you've painted is, I have to wait for an alternative, but I can have AZ now. I think I'm telling you that we've looked at the supply carefully enough to know that we can make the change required by JCVI and stay on track and stay absolutely on pace, point. So from that perspective, I don't really think it's going to be a very common scenario at all that you describe. Thank you. Next question is from Chris Smythe at The Times.
Thank you. Can I first just clarify, is any of this change because the concern about blood clots has gone up, or is it pretty much all because concern about COVID has gone down with the improvement of the pandemic? And just to follow up the point about the preferential use, so if someone under 40 books appointment goes along and finds that they're being offered AstraZeneca, can they say, no thanks, I'd rather book in for another time for a different vaccine, or do they just have to accept that's what they get on that day?
Professor Lim.
So the benefit-risk ratio obviously is a benefit-risk ratio, taking into account both sides of that equation. And I would say that the bigger change has been the change in the projected COVID-19 infection rates going forwards, as well as the potential size of any further wave of infection compared to projections made previously. So it's not that the safety side or the risk from these extremely rare adverse events has gone up dramatically. They are still extremely rare.
Thank you, Professor Lim. On the point about kind of bookings and, you find you're not offered what you thought you were going to be offered, the whole point about, being confident about the supply situation is that people will now be offered what is being advised by JCVI. So, in a sense, again, it's a bit of a theoretical argument. I don't expect it to apply to many people at all. I am very assured that the NHS will be able to enact the JCVI recommendations without impacting scale. But in this country, we don't force people to have medical treatments. We don't force people to have vaccines. We never have done, and I don't anticipate we're going to start any time soon. Anything to say on that?
Perhaps a word again about the evolving picture on the incidence rates. Because of the welcome focus on this issue, many healthcare professionals have been looking back to see if there's anything they can tell us. So much of this apparent small increase in the incidence levels is related to that, and it helps us very greatly with our investigations into risk factors and so forth. So we very much welcome reports, but we obviously look carefully at when the vaccine was given and when the event may have happened. So some of these increases are due to that process.
And I think the biggest point about the announcement we're making today, about the announcement that JCVI are making today, is that this further de-risks our programme, and the JCVI and the MHRA are really all over this and keeping a very close and conscientious eye on this for us, as we'd expect them to do. Thank you. The final question this morning is from Anna Goss at the FT, Financial Times. Thank you.
Hi there, thanks a lot for the briefing. My question is for Wei Shen Lim. Is there any regret amongst members of the JCVI that the decision wasn't made a month ago when the same advice was given to those under the age of 30, given that chopping and changing may, A, fuel vaccine hesitancy, and also given the fact that 8 people in that age group have actually now died?
Thank you. We have to formulate our advice, shall I say, based on the best available evidence. And a lot of the data that we've examined in the last 2-3 weeks really has just come out. Indeed, some of the models that we talk about projecting the different scenarios that might occur in the next wave of infection really have only been completed in the last few days. So we are, if you will, responding to the newest and the latest data and providing advice accordingly. It's not really a case of looking back and trying to retrospectively think what we might have done without the available information. So I would say that 1 month ago we made the best advice we could based on the best available evidence then, and we're giving the best advice we can now.
Thanks, Professor Lim. I think I would just kind of add on top of that in the vaccines for public health deployment arena, you have to also always factor in the lives that are saved by vaccines that are somehow hidden from our view because the deaths don't happen, the lives are saved. And that's the difficult balancing act and the judgment that these professional vaccinologists and epidemiologists on JCVI have to live with and make every day, and it's very difficult work, and I think they do an absolutely phenomenal job under the very difficult circumstances. Thank you very much, Anna. That concludes the questions. I would like now to begin the closure of this briefing by reinforcing just a few points for everyone. The first thing to say is that I believe our COVID-19 vaccines are safe and effective, and that they are reducing severe COVID-19 in the UK. They are also now slowing transmission, and we already have formal estimates that they have already saved over 10,000 British lives. But actually the greater value of these vaccines is the lives they will save in the future by keeping the disease under long-term control. And that is why we must finish the job. The MHRA deals with patient safety and the conditions of authorisation and licensure, and you've heard from the MHRA today that they are not making any changes. The JCVI has a different role to advise government on how vaccines should be used in a public programme, and the JCVI had advised again today to keep COVID under control. We have to maintain the pace and scale of the UK vaccine programme. If it slows down, then we increase the chances of an earlier and more dangerous third wave. On reviewing the data on extremely rare blood clot related side effects associated with thrombocytopenia, and also the overall context of the UK vaccine programme, including UK epidemiology and including supply, JCVI now supports the argument that favours the use of vaccines other than AstraZeneca in adults aged 30 to 39. I want to emphasise very strongly that this does not mean that JCVI advises against using AstraZeneca in 30 to 39s, only that where possible it prefers something else consistent with maintaining pace and volume of the programme. So I've already seen a couple of headlines about AZ being banned. Sorry, not true. Our current plans, our vaccine supply schedules, will support the change being advised today without limiting speed and scale of the rollout, and we're still on target for that first dose to all adults by the end of July. There will, as Professor Lim said, because of the deployability of AstraZeneca, still be a number of patients where it is only practical to offer AstraZeneca to them because of the circumstances. But on balance, it's better to make this further course correction as long as there is no substantial delay. And JCVI have been very clear that their advice is conditional upon that. People under 40 who have started a 2-dose course of vaccination with any of the UK vaccines should continue to receive the second dose as scheduled. There are currently no safety concerns regarding rare blood clot events with second doses, and I note that over 6 million second doses of AstraZeneca have already been given. JCVI is also very clear that in the 30 to 39 age group, any of the UK vaccines offered in time is always better than no vaccine unless there are specific contraindications as advised by the MHRA. So to keep control of COVID, we've got to keep up the pace of the vaccine rollout and to finish the job. And that's why I urge you, when you're called to get a jab, when it's your turn, please come forwards. And crucially, remember that the second dose gives you stronger and longer protection. I can't say it enough times how grateful I am to the MHRA and the JCVI for their continuous diligence, watching over us on this and keeping the vaccine programme in the best shape it can be. And finally, I'm going to say a few slightly more, I guess, emotive words. Sadly, many people have died in this pandemic so far, but thousands are alive today. They avoided death, they avoided the intensive care unit, they avoided the hospital because of their own good sense in coming forwards for the vaccine, and because of the protection that the AstraZeneca vaccine and others have afforded to us. There are layers of protection too, and we now see very clear evidence that these vaccines are transmission blocking. So there will be other people who've been spared COVID-19 because of the actions of others in getting vaccinated and through that process not transmitting it on to that person. I estimate that in the next few months, and I hope for a horizon at least as long as a year, many thousands more people in this country will continue to avoid COVID-19 altogether, avoid hospitalisation and avoid death because of what the vaccine that they have had or they are going to have will do for them in the future. And it is those future effects for people who've either had the vaccine or who are about to have it that is really critical here. And I hope you all continue to support the vaccine programme, and we will do our best for you to finish the job. Thank you very much. This press briefing is now concluded.